All right. Well, thank you everyone for joining. My name is Dr. Amy Bender. I'm the Director of Clinical Sleep Science at Cerebra. We're very happy for you to be here and to be joining us for the Sleep Rounds with Dr. Magdy Younes, hosted by Center for Sleep and Human Performance. I just wanted to touch on how the rounds work. So we have Dr. Younes, who will be presenting on a new way of looking at sleep architecture using ORP to provide more information from the PSGs. He's going to apply this approach to difficult cases provided by Center for Sleep and Human Performance. And then we have allotted 10 minutes at the end for questions. So make sure you use the Q&A function for any questions that you have. And then after the webinar, we're going to be sending an evaluation form. Would like to get your feedback on how we can improve the rounds, as well as potential topics you want to discuss in the future. So I'm going to introduce our speakers for today. We have Dr. Charles Samuels, who's going to be our moderator for today, and whose clinic is providing the cases for today's rounds. Dr. Charles Samuels is the medical director of the Center for Sleep and Human Performance in Calgary, Alberta. He is a diplomat of the American Board of Sleep Medicine and a member of the College of Family Physicians of Canada, and has also served as Vice President Clinical of the Canadian Sleep Society President, and is the chairman of the Alberta Medical Association Insomnia Clinical Practice Guideline Committee. Dr. Samuels is a clinical assistant professor of medicine and adjunct professor in the Faculty of Kinesiology at the University of Calgary. He is a well-respected medical educator who speaks internationally on topics related to sleep health and human performance. And then we have Dr. Magdy Younes, who will be giving our presentation for today. Dr. Younes is a distinguished professor emeritus at the University of Manitoba. He has been a clinician scientist, university professor at McGill University, University of Texas Medical Branch, and finally the University of Manitoba, where he served as head of respiratory medicine and the sleep laboratory at the Health Sciences Center in Winnipeg. Dr. Younes's research in respirology, critical care medicine, and sleep medicine has resulted in 162 original peer-reviewed papers and 22 book chapters and reviews and numerous patents. He is the inventor of Michelle Sleep Scoring, the Prodigy Sleep Monitor, and proportional assist ventilation, the Winnipeg ventilator, and the ORP continuous measure of sleep depth index, which we will be featuring in today's rounds. I'm going to pass it over to Dr. Samuels, who's going to talk about the particular cases that we're going to be going into for today.
Great, thanks, Amy, and welcome to everyone. It sounds like we have over 90 people on the conference call today, and some good cases, and of course Magdy is always insightful and entertaining. So I'm just going to give very specific details and turn it over to Magdy, things from these cases. I think one of which is actually my patient and the other is another doctor's here. So the first one, JM, is a 64-year-old woman with a complex sleep and mood history. So the bottom line here is that she is a very complicated psychiatric patient with rather severe initial and maintenance insomnia. When she presented to us, had been actually all over North America to different clinics for help with her psychiatric illness. Some treatment had included a trial of ketamine and also ECT in the past. So as you can well imagine, it was quite complicated. By the time she got to us, she was really only on clonazepam, 0.5 milligrams TID, and she was tapering off 15 milligrams of Remeron, and now on really a micro dose of 0.5 milligrams. So really it's not therapeutic. Bottom line here is using the ESS as a metric, a general metric of daytime performance. She certainly wasn't struggling with daytime sleepiness with an ESS of 6. And she had had 6 visits in the behavioral sleep medicine program, and her ISI at the baseline was 17, and at her last visit was 22. So not a lot of change with behavioral sleep medicine, and she had actually had the full program of 6 visits. those are the key features in that case. The next one, Amy. So for LP, a 42-year-old woman with symptoms of insomnia, restless legs, OSA, when she presented, and she had never been prescribed any sleep medication for insomnia, and she had a 20-year history predominantly of insomnia with some vague symptoms of possible RLS and a low to moderate pretest probability of OSA. Her baseline ESS was 8, so relatively normal. And again, similar situation, her ISI at the start of behavioral sleep medicine was 9, and there was no change over, I think she had had 1 or 2 visits in the chart when we got this together. And in her diagnostic, she was given the 5 milligrams of zopiclone. She had a good sleep efficiency with zopiclone. So with that, I'm going to turn it over to Magdy and take it away.
So the topic today will be specific about insomnia and how ORP can be helpful in the management, or at least we think it might be helpful in the management because clinical trials are still ongoing. What I will tell you today is all published, the basis for it and the associations with and all that is published recently, was accepted in Sleep. This is sleep architecture based on sleep depth and propensity. And it is already online in Sleep, and it's open access. So if you go there, you can get it without any problems. So what we're talking about is how to use ORP to evaluate sleep architecture in order to supplement the conventional ways of describing sleep architecture. And ORP is just a continuous index of sleep depth. Instead of having a staggered levels of sleep depth, as in the RNK system, this is a continuous one that is measured every 3 seconds. And it ranges from 0. So if ORP is 0, it means the patient is in very deep sleep. And if it's maximum at 2.5, it means the patient is full wakefulness. And of course, we have everything in between. So this is a representation of how conventional sleep architecture is described. You know, in numbers, but you can do it in base. So this is a normal person, has 14% awake time, sleep efficiency of 86%, a little bit of N1, a lot of N2 as usual, some N3 and some REM sleep. But the important thing that distinguishes ORP from this is that awake stages is not the same. You know, not every epoch is the same. And N2 is also not the same. So we don't really, from this architecture, we don't really get information about how deep the sleep is within these different stages. So to explain that, I have here 9 or 10 30-second EEG strips that start with full wakefulness and ends up with stage 3 at the bottom. So the first 3 panels would all be scored as awake, but you can see visually that they are very different. The top one is fully awake with a lot of beta power. The second one doesn't have as much beta power or alpha power, but it has also a little bit of theta, if you can see what I'm pointing at. The third one is also still awake, even though there are some mini sleep periods, but they don't add up to 15 seconds. So we're calling them the patient still awake. But if you look at the ORP, you can find there is gradation here between these 3 epochs. Of course, there is all kinds of gradations in between the top and the third. 2.4 is very close to 2.5, which is full wakefulness. 1.8 is pretty much getting close to sleep, and you have everything in between. So this is the advantage of ORP over just telling you that you know, the patient spent 14% of the time awake. With ORP, we can say that when he was awake, his average ORP was closer to 1.7, 1.8, which means this was not really fully awake, but he was drowsy. And on the other hand, if his average ORP is 2.3, it means that most of the time he was awake or she was awake, he was in full wakefulness. And as you will see, or as you have seen in published papers now, that if the average ORP awake is pretty close to, is very high, it means the patient is not sleepy. He's not he's got very low sleep pressure. On the other hand, if the average ORP is in the neighborhood, is less than 2 particularly, it means that he's just trying to go to sleep, but something is preventing him from going to sleep, which physiologically are very different states, even though they're both called awake. Now we spend about half the time in N2, and I have here 4 panels, all of them scored as N2. The top one is pretty similar to the awake and N1, except has a spindle, so it's called stage 2, but the rest of the EEG is very much like awake or stage 1. And then as the patient gets closer to the deep sleep, you can see there is less beta and there is beginning to be delta waves. Here in the next to last panel, he's got delta, but they don't add up to 6 seconds or 20% of the epoch. So it's still called 2. With an extra delta wave or something, it becomes stage 3. But so there is very little difference between deep stage 2 and stage 3, whereas there is little difference between the early stage 2 and the awake. And if you look at the ORP, you can see that you are covering a huge range of ORP from almost awake 1.77 to almost stage 3. I must also remind you that you don't have to be in stage 3 to have very low ORP, because in many people, the delta waves don't add up to 6 seconds, even though it's clearly a very deep sleep by the ORP and also visually. So the new ORP architecture is going to be like this, is what we are proposing, which is taking the full range from 0 to 2.5 and breaking it into 10 deciles. And we are expressing what percent of total recording time is in each decile. So between 0 and 2.5 and 0.25 is very deep sleep. This is like here, like here, 0.25 to 0.5 like this one, and so on. So as the ORP increases, the sleep depth decreases, and in a normal person, most of the epochs are in this second and third decile, and then they drop off. The middle ones here between 1 and 1.75 are transitional states, like you see here. There is sleep patterns and awake patterns, and then finally you get into the last 3 deciles, which are usually scored awake, like these top 3, but with differences. 1.75 to 2 would be like this one. 2, oh, I don't know, the scale is messed up. Between 2 and 2.25 will be like this, and the highest one is full wakefulness. So this is the idea, is we're going to express sleep depth as percent in each of the ORP deciles. Okay, so this is a normal person. Once we came up with with this particular way of describing it, we started looking around in lots of patients, and we found very different patterns that we look at. And I have these 4 patients from the Sleep Heart Health Study, and these are their conventional numbers: total sleep time, efficiency, different stages, arousal index, and so on. And if you look at each of these, for example, total sleep time is pretty much the same. Sleep efficiency, however, is a little bit low in subject number 2. But, I mean, it's not very specific. N1 is about the same. Everything is within normal limits. Many people don't have stage 3, especially when they're older. REM sleep is the same, arousal awake. Everything here looks normal, except for low sleep efficiency in this patient. And yet, with the ORP histogram, you can see that the patterns are really quite different. So how do we interpret these patterns? I mean, these patterns must have some underlying physiological basis. So one of the things we did is there is a study in twins. They don't have to be twins, but very young, healthy people that were subjected to 36 hours of sleep deprivation. So this is their baseline, which, as you can see, is pretty normal. And this is after 36 hours of sleep deprivation, which means their sleep pressure is very high. So we are trying here to see what is the effect, how does sleep pressure affect this histogram. And what you can see here, these are all the same people. You can see that deep sleep increased quite a bit, and transitional sleep decreased a lot, and full wakefulness also decreased. Every time you see an arrow, it's significant. On the other hand, the lower two panels, it's the same patients again, 2,200 of them, but we are looking at the first half of the PSG versus the second half of the PSG on the grounds that we know that in the second half of the study, the patient's sleep pressure is less because he's got already some restorative sleep. Now, what you can see is the opposite now, is that deep sleep went down and full wakefulness went up and transitional sleep went up. So as our sleep pressure goes down, we have less deep sleep and more light and transitional sleep and more full wakefulness. So this now allows us to start interpreting these patterns. Here, this particular pattern, the patient has very little deep sleep, which we define as the sum of epochs in the first and second decile. So you see this patient here is only about 2 or 3% in this deep sleep, by contrast to 27 or 28% in a normal person. So why would the deep sleep be very low? It could be one of two things. One is that the patient has very low sleep pressure. So maybe he's just sleeping too much during the day or something. He doesn't have much sleep pressure. Or it could be because he has some disorder that prevents him from getting into deep sleep, such as OSA or PLM. So every time he tries to go to sleep, one event wakes him up and he never really gets to deep sleep. So there are two possibilities to explain this pattern, the low deep ORP. But if he had very low sleep pressure, we would expect the full wakefulness to be high. So this pattern then tells us that this is likely the result of a sleep disturbing disorder that prevents the patient from getting into deep sleep. So he spends most of the time in very light and transitional sleep. And as a result, he's got high sleep pressure and he has very little full wakefulness. On the other hand, subject 2 also has very little deep sleep. The sum here is about 5. So the same two possibilities, low sleep pressure or this disorder is preventing him from getting into deep sleep. But the excessive amount of full wakefulness tells us that his sleep pressure is not high. And therefore, this is a patient then that the underlying physiology is probably someone with very low sleep pressure. That's why he doesn't have deep sleep and has a lot of full wakefulness. Now, this guy, you remember when I showed you the previous, see this one? This is the exact pattern of sleep deprivation, a lot of deep sleep and hardly any transitional and full wakefulness sleep. So this pattern then, based on what we know, suggests that the patient is not getting enough sleep, so he's maybe needs more sleep. And this one is the odd one. Then he's got high in both of them, in the deep sleep and the full wakefulness. So how do we explain that? We can explain it by saying, well, I mean, there's nothing wrong with his sleep, but this patient is, either is a short sleeper who gets enough sleep from just few hours, and so he spends the rest of the time fully awake, or it could be a circadian problem. So someone who has delayed sleep phase or advanced sleep phase would spend part of the night awake, fully awake, because it's not his time to sleep. But when he goes to sleep, he's got very good sleep. So this is the basis really for interpreting these different patterns. And we ended up, just to make it, quantifiable, is to break it down into 9 different patterns. 3 that have, and the way we divided them is because is based on the how often do you have deep sleep in a large population. So we looked at Sleep Heart Health study, which has about 5,000 patients, and found that a quarter of the subjects have less than 10% of their time in deep sleep, and so if the first digit is 1, this one is type 1, means the deep sleep is in the lowest quartile of all the sleep heart study patients, the 5,000. And the second digit describes where the full wakefulness is relative to the sleep heart study patients. So the lowest quartile is less than 3.4. And so this patient then is 1-1. So when you see 1-1, you can immediately visualize the architecture, and that this is a patient who has very little deep sleep, but at the same time, he has very little full wakefulness. And as you go to the right, it's the same thing. All these 3 patterns, they have very, very little deep sleep. The first digit is 1, 1, 1, 1, but the second digit increases progressively, as you see. So less than 3 is the first quartile, between 3.4 and is the interquartile range, and full wakefulness, there are a quarter of the people have full wakefulness more than 12%. So this is why it's 1-3. And the same applies to the other patterns. So this bottom one here, 3-1, means the patient has a lot of deep sleep and very little full wakefulness. And this one has a lot of deep sleep and a lot of wakefulness, so he's 3-3. So I think, the nice, one of the advantages of this characterization, instead of the conventional thing, you say sleep efficiency is 85% and N1 is 2%. You can't put all these together into one pattern. This one, with a single 2-digit number, you can immediately realize what the architecture is. And this is what we're going to use in analyzing or explaining these patients. Now, in this paper that I referred you to, we don't have to go through this. It's just to make you aware of the presence of this table, which is called Table 6. That here are the 9 patterns from 1-1 to 3-3. And there is a column that says what is the suggested physiological mechanism. And what did we find in the Sleep Heart Health study is associated with this particular pattern, whether it's excessive sleepiness or quality of life and so on. And here are the suggested clinical interprets, highlight suggested, because these are just ideas for clinical research, where if you follow the recommended interpretations here, we want to know whether it is justified or it gets rejected by the clinical trials. But it's something to help you do research or to try to sort of make sense of the different architecture in different patients. We won't go through all this. We'll go through some of them as we go through the patients. So the other thing we found in the Sleep Heart Health study, which again illustrates the benefit of ORP, this is a table of the conventional sleep variables in different clinical groups. There were 4 OSA groups and 3 insomnia groups, and these are the conventional indices. So it's basically comparing them to each other. But because today we're not talking about OSA, I'm going to blank this out. I'm going to, and I'm blanking also insomnia plus OSA. And this is just to show you the difference between insomnia with normal sleep duration and insomnia with short sleep duration by conventional criteria. So there is no difference in total recording time. You see the total number here for normal sleep duration is 180 and short sleep duration is 80. So there is no difference between them in total recording time. There is normal sleep duration is a bit higher than people with no insomnia. Short sleep duration is much lower, total sleep time, which of course, by definition, it is. Sleep efficiency is also different. This is higher than no insomnia. This is lower. And now we get into the sleep depth variables. It's slightly higher in the short sleep, in the short insomnia or short sleep duration, but nothing to write home about. But what is important then is the stuff that you really use for deep sleep. There is no difference in N2% total sleep time between normal sleep duration and short sleep duration. No difference in N3 time. No difference in REM time. No difference in arousal awakening index. No difference in AHI. So this is the reason, if you remember, we used to do sleep studies on people with insomnia. And then people got sick and tired of doing sleep studies and getting nothing from them other than just, well, there is excessive awake time, which, you don't really need such a sophisticated test. So the recommendation of the ASM then was that you should not do PSGs in insomnia patients because they don't help. And this particular picture shows you why they don't help. There is really hardly any difference between them other than less awake time, more awake time. The other thing we found from the sleep heart health study, I'm going to blank out the OSA to leave it with insomnia. So here, let's see whether the different patterns are the same also in normal sleep time and short sleep time. So this is one of the highest types in insomnia with short sleep duration. 1-3, this one, like I told you, hyperarousal pattern, no deep sleep and a lot of full wakefulness. You see how rare it is in normal sleep duration. It's much lower than even people without so very, very different from each other, these two patterns, these two types of insomnia. And here is another pattern, 2-3, which has good deep sleep, but also it's sort of like 3-3. So both the deep sleep and the full wakefulness are high. You can see that this is the most common pattern in insomnia with short sleep duration, 38.8%, much higher than the people with no insomnia. The ones with normal sleep duration is much lower. So, okay, so this shows you that normal sleep duration and short sleep duration are really very different disorders, and because there has been some question about whether they are just two expressions of the same thing. So that ORP then helps us distinguish NSD from SSD. But the other important thing is that there are two dominant types in insomnia with short sleep duration. They account this one for 29% and this one for 30%. So between them, they account for 70% of all cases, 1-3 and 2-3. Now, what is the difference between these two patterns? 1-3 is this hyperarousal type. It's primarily seen in severe OSA also, which is called COMISA, but it's seen in insomnia short sleep duration. It's associated with less sleepiness, very low quality of life scores, high risk of blood pressure, and high and low survival. So, and high ORP, this is sort of a marker of hyperarousal state. So this is a very bad type to have, and is probably responsible for the many reports from Penn State University that show that insomnia with short sleep duration have a much higher morbidity. Now, what about the second one, 2-3? These people have deep sleep, good deep sleep, but also the excessive full wakefulness. It's primarily seen in insomnia short sleep duration because by definition, they have a reduced sleep time associated also with low SS, which means it's also associated with low sleep pressure. but it has normal quality of life scores, no increased risk of high blood pressure or survival, and no evidence of hyperarousal. So these are two very, very different patterns that both account for the vast majority of insomnia sleep. And it is important then, what we think is to distinguish between these two patterns within the patients with insomnia of short sleep duration, which are now considered as one phenotype. And then we move to the patients. Chuck summarized this patient, 64-year-old woman with sleep and mood history and insomnia, ISI 17, no significant medications, migraine. She suffered from severe depressive disorder and anxiety since 2020, and her sister has OSA, and she thinks her father has OSA. So, okay, so we do the conventional sleep study, and this is the histogram you are used to. Well, I mean, it looks pretty good other than excessive awake time here and at the end of the study. And you look at the conventional indices, so she has less than 6 hours. That's why she is insomnia with short sleep duration, low sleep efficiency, a little bit late ORP, sleep onset, WASO is excessive, REM latency is okay, stage wake 2 hours and a bit, which is why she has insomnia with short sleep duration. N1, N2, N3, many people don't have N3, normal amount of REM, normal arousal awakening index. There is nothing really special here that helps you figure out what's wrong with this patient. I hope you agree with me on that. So now we start doing ORP, and Chuck has been kind enough to send me the sleep records, and we run the ORP on it. And what you see here is the different sleep cycles. With every sleep cycle, ORP goes down, down, down to a minimum value, and then they usually either wake up or get REM sleep. And this is an abbreviated cycle. This is another cycle, but they didn't get REM here. But anyway, it looks pretty, even the ORP looks pretty good, except if you have an eye for these things, you will see that the deepest sleep this patient gets into is just a little under 1, which means she doesn't get much deep sleep at all. There's nothing basically under 0.5. So that means that she has problems getting into deep sleep. The other thing I want you to notice here, which is again a brand new information, REM sleep was a binary kind of decision, you're either in REM or not in REM, but nobody bothers to comment on the depth of sleep when we are dreaming. You can see here this patient, whenever she is in REM sleep, the ORP is almost 2.5. In other words, and I sent, like our scoring system cannot pick up REM when ORP is more than 2, because that by definition is awake. So there is, maybe 1% of patients have ORP REM in the awake range, and it's very hard to then score REM. You really have to wonder about every epoch, is this awake or is this REM? So this is another finding using ORP in this patient that we are discovering for the first time. And we are in the process of trying to find whether, because there are lots of papers about associations with REM quality, not sleep depth, but fragmentation and so on, and mood disorders. So we are now looking into the relation between ORP, REM, and mood disorders, but we don't have any data yet. So these are two interesting. So what about the numbers? So I'm giving you the ORP for this patient in different sleep stages. ORP awake is 2.29. This is the range. And, people keep asking me, what is normal? There is really nothing normal in these numbers. Each number tells you whether sleep depth or wake propensity was high or low in this patient. But to sort of come up, you have to comment on the whole pattern as to whether it is normal or not. But every number, so people with can have a very high awake ORP, which means low sleep pressure. But if they have deep sleep, then it may be just that they had too much sleep, and so on. So there is nothing normal. But here it tells you that this patient, when she was awake during the study, her ORP was pretty close to max, which means her awake time was in full wakefulness mostly. N1 is very high, as you will see the other patient. N2, she had no N. RAM is 2.17. You see, so it's almost at the top of RAM, like top 1% of the REM range. And for all of non-REM, the average ORP is somewhere in the middle, which, it's a skewed distribution. So 1.18 is quite high, actually, indicates poor sleep. And all the recording is 1.6. So if you average all the recording together, it's the patient is almost awake. So then we get into the patterns. So this is the pattern of this particular patient. Again, very little deep sleep and a lot of full wakefulness. And this, like I told you, there is nothing under 0.5 here. That's why there is nothing here. And there is a lot of over 2.25, because you see when she's awake, the ORP is almost at 2.5. Anytime she's awake, it's at 2.5, and so on. So this is the pattern that, comparing it with the normal subject, you can see the difference. I mean, you don't have to think too much about the numbers. You just look at it and say, she has very low deep sleep and a lot of full wakefulness. Therefore, she's type 1-3. Okay, so she's type 1-3. That's what we found. Now, what does type 1-3 mean? So here is the big table in the paper, and we can't read this, at least I can't. So I magnified it for you. Type 1-3, it says with the obvious, little deep sleep suggests either low sleep drive or sleep fragmenting disorder. So then you have a high sleep pressure because you don't get deep sleep. But the increased amount of full wakefulness and the high ORP wake, remember it was 2.19, that doesn't mean that she doesn't have high sleep pressure. Therefore, it suggests low sleep pressure, and this is the kind that we said suggests that there is a sleep fragmenting disorder, which could be in the brain. It doesn't have to be sleep apnea. It could be some, you can't turn off the brain or something preventing you from getting into deep sleep. When you are awake, you are fully awake. And I told you it's associated by terrible things, quality of life, but it is normal in old people. This is what happens. So my pattern would be 1-3 because I'm 82. So, but a young person would never have this pattern. It is very rare in younger people or symptomatic older people. So if you see it in a younger person, this is a red flag for insomnia or going to have insomnia. But if you see it also there, it can be associated with OSA, where if you have OSA at the same time as this pattern, then when you treat the OSA, the patient will probably benefit from CBT at the same time. So 1-3 is a very bad deal, and this patient then, my personal feeling is because it's more of a neurological problem, not a lifestyle issue or sleep habits issue. My feeling is that it will not respond very well to CBTI. So we had an argument yesterday with Chuck. So she had CBTI, and he said the patient improved. She said she's much better. But as he told you, that her ISI was even higher than before. So did she respond or did she not respond? This is something that we have to wait for additional information to decide how to determine whether CBTI works. And the other thing is, what are the implications of very high MORP? Again, this requires research. And when you see it, if you start using ORP, when you see it in your laboratory, keep track of these patients, because they are very, very rare, and they will definitely, I think, show some abnormalities clinically. So that may be a relevant finding. So again, this is the insomnia NCD and SCD. It's just to show you that this pattern is bad, but the 2-3 and the 3-3 below, same thing. They are benign. And so if you find this, you know, like again, a proposition, a hypothesis, these people are not responding very well in CBT, at least objectively, whereas these people, you don't have to do anything for them except, you know, except do CBT, because that's almost always related to lifestyle issues or circadian issues. So I just want to go quickly to the actual record so I showed you this before, but what I would like to show you is how, remember, an ORP here is almost 2.5 when she's awake. So I put the cursor here at this point, so you see what 2.5 means. The ORP here is 2.46 for this epoch. So let me see, just so we don't waste anything. We don't waste time. If I go to 896,
Magdy, while you're just doing that, I want to correct things. I went back to the chart and she actually has not responded to CBTI.
well, why did you tell me not?
No, because we confused. Remember, we had two different cases that we were discussing
So
yesterday.
she didn't, so I was
She
right.
actually didn't. You were right. Magdy, you're always right.
Okay. As long as you admit it, Chuck, that's fine. So here, so compare this epoch. You see the ORP here is 1.86, but she doesn't have 15 seconds of sleep, even though you can see that there is sleep here. So this is what we call drowsy sleep. The patient's trying to fall asleep. So this illustrates the difference between an ORP of 2.5 and an ORP below 2, right, awake. Okay, now we go back and we finish it off by talking about the next patient. So again, the next patient, Chuck, this is a much younger woman and has complaints of insomnia, RLS, and OSA, and was never treated, no significant history. And you look at this sleep study, and again, all you can see is some excessive awake time, which adds up to 90 minutes. And N1 is excessive, N2 is okay, N3 is okay, REM is okay, arousal awakening index is 32, high, but again, no OSA or evidence of restless legs or PLMs. So now we do the ORP. Oh, because I didn't do that. Okay, so now we do the ORP, and ORP awake is still quite high, which again means that she has low sleep pressure. It's very close to the upper end. N1, if you remember the other numbers, we'll compare them later, but this is much lower than in the other patient, much lower, and all non-REM is much lower. We'll look at a comparison. So this is, so here the sleep is deeper in all stages, but it's high in stage awake. And now we look at the pattern. Again, this is the normal pattern here. And you see that compared to the normal pattern, she has a lot more deep sleep, but also more full wakefulness. So that puts her in the 3-3 category, meaning that her deep sleep, the sum of these two, is in the upper quartile of people. and their full wakefulness is also in the upper quartile of people. So very different pattern from normal and very different pattern from the other patient. So this is to help you compare the conventional indices of the two patients. And they both have low sleep efficiency. Sleep onset is shorter in this patient. The second patient, WASO is the same. REM latency is still normal in both of them. Stage wake is 90 minutes, a little bit less, but N1 is more. N2 is the same. N3 is a bit more here. Arousal awakening index much higher here. So the second patient is worse in certain things that characterize insomnia. The other one, and the other one is worse in terms of total awake time. But it doesn't really help you very much. They could both be classified as insomnia with short sleep duration. And and these are the two types. And you can see with ORP that you can easily distinguish these two. This is 1-3 and this is 3-3. And if we go to the comparing the numbers, you see they have the same high ORP awake, low sleep pressure, but the ORP of N1 is much lower here, much lower here, much lower here, much lower, much lower. So this patient had a lot more deep sleep, but still had a lot of full wakefulness. So now we go to this big table and zero in on 3-1. Zero in on 3-1. And here we go. It's a combination of increased deep sleep and the excessive amount of full wakefulness suggests short sleeper or circadian misalignment. Why do we say circadian misalignment? Because if you have a delayed sleep phase, you don't usually go to sleep until, you don't feel sleepy until midnight or 1 o'clock, and you go to bed at 10 or 11, you're going to spend a couple of hours, with the fully awake. But when you go to sleep, you go to sleep very well. On the other hand, if you have advanced sleep phase, you may sleep very well at the beginning, but not at the end. You may be fully awake when you are outside your cycle, but have very good sleep when you fall asleep, when you are in phase with your circadian rhythm. So this is very rare in all demographics. It's not associated with any adverse health outcomes. So what we think here, when you get a patient like that, again, all that needs to be confirmed. It suggests that the patient is a short sleeper, so he doesn't need a lot of sleep. But everybody tells him you have to sleep 7 or 8 hours. So some of the time he just doesn't have any sleep pressure. Daytime symptoms, if they are present with this type, they suggest circadian misalignment for the reasons I mentioned, or lifestyle issues, like napping during the. So this is a very different kind of pattern that requires different treatment from the first case. And we suspect that this patient will improve on CBTI, but we need to confirm that. Does this pattern respond to CBTI? We'll have to see. Then we want to go to the viewer, and this is my last. Here is, you've seen the bottom one before, I've shown you. What did I want to use this one for? So look, yeah, see how much, if we draw a horizontal line at 0.5 here, you see there is an awful lot of sleep below 0.5 in the very deep sleep, which is different from the other patients. And in both of them, you will see that the ORP in general tends to go up as the night goes on, which means we're getting more restorative sleep. And the higher the ORP at the end of the night, the more indicative it is that sleep was restorative. Whereas if the patient at the end of the night is still getting very deep sleep, it probably means that he has idiopathic hypersomnia. So the last point I want to show you in LP is to again, so here the CORP here is, and you would agree that this is full wakefulness, it's just alpha wall-to-wall 2.49. But this patient now is getting into sleep, but before he gets into deep sleep, you know, his ORP starts going down. And so I want to show you again, this is now 1 epoch later, it's gone from 2.49 to 2.04. And you can see that we are beginning to get little bit of sleep here. So the ORP went down. Oops, what am I doing? But what's going on here? Okay, you see now that he's getting now a little bit of sleep during this epoch, and it's going down still. We have a bit more sleep here, and so on. It's just to give you an idea that these numbers really mean. Okay, we're going to stop here. This is all I want to say, and thank you very much. Any questions?
Okay, before we get to the questions, I'm actually gonna share the QR code for the paper. So if anyone wants to get that paper, I'm gonna share my screen here so you can see that. So feel free to use your phone, pull up the camera mode, and then hover it over the QR code. And then that will take you directly to the paper that Magdy was referring to in the presentation. And I'm going to pass it over to Chuck, who's going to moderate the Q&A.
Sounds good. Thanks, Amy, and thanks, Magdy. Very insightful, and it evolves as we have more and more rounds. I think all of us get a better understanding of the implications of the various patterns that you've come up with in the work that you've done. So we have one question from Sonia, who has thanked you for a wonderful lecture, and I'm wondering if you actually can speak to this, and I expected this. How is the clonazepam interfering with the quality of sleep? Would you expect a different pattern other than sleep time in the first patient, JM, who was on clonazepam? So I think one is the clonazepam, two is what's your insight on medications in general, or is that to sort of be disclosed in the future as you do more research?
Well, I mean, we haven't yet done a systematic analysis of the histogram in different drugs. Yeah. But benzodiazepines in general, I mean, they're not going to give you excessive awake time and would not make sleep lighter, I mean, if anything. So the clonazepam cannot explain the type 1-3 for sure. But benzodiazepines usually don't give you excessive awake time, but they don't improve sleep depth. But I have really like you said, I have no experience with clonazepam in particular, and that's another area of investigation that is open for investigation. And like I said, I'm very old. I don't have my own lab anymore. I don't do clinical research. But anytime you have a question, you want to address a question in your clinic, just let me know and we'll give you the information and you can write the paper. But there's just no end to what questions one can ask.
Yeah, and I think it makes the point, she was on clonazepam and still her sleep was very light. And so that's actually quite interesting and reinforces the clinical impression of the patient as being a complicated psychiatric patient. From Najib Ayaz, great talk. In the SHHS study, was insomnia with short duration based on objective sleep by PSG? If so, how representative is it of regular sleep duration? Actually, that's a great question. Can you speak to that, Magdy?
Well, yeah, all the sleep heart health study patients that were diagnosed with insomnia, they had PSG, and they had less than 6 hours of sleep time. So there's no question about that. But how representative it is of the clinical population, or how representative? I think it is, but I can't swear to it. I mean, like for OSA, for example, we find that the ORP for the same severity in the sleep heart health study, it's the same in the clinical study. Maybe the clinical patients have more complaints. I don't know, but I can't answer that. Again, this is another thing ripe for further studies.
But they did use the standard definitions used, Najib, in clinical trial work in insomnia. So that was used, and your point is well taken, but that is a standard when using objective data in clinical trials of insomnia with pharmaceutical agents. I hope that helps to answer. One more question, because we're getting close, from Gustavo. Do you have any studies on healthy people and age differences using ORP, I'm assuming is what he's asking?
Oh,
Jet
yeah.
Norman of data. Yeah.
If I can show you
You got 3 minutes.
yeah. Can I share?
Sure. While you're doing that, a question of, do you think we can choose pharmacological treatment based on category? And I think just to answer that, Leila, that is actually the goal in the future, is to actually have typing that would help us make choices pharmacologically. We're a long way
because
away.
as you all know, that not everybody with insomnia responds to the same drug, and that between that and Prodigy, which Amy has, that you have the ability now to monitor ORP and the whole sleep stuff at home, and you can do many studies. Like she did in 20 people, she did 20 studies in a row each, so that you can actually monitor the patient with different regimens over successive nights for a long time to determine what is the best drug and the best dose. So, but this is the effect of normal people with no OSA or insomnia, and the effect of age, for example. So this is decile 1, which is the deepest sleep. We can see that as we age, go from white to black, it goes down. The deep sleep goes down, but the light sleep and intermediate sleep and awake goes up. So we are moving towards 1-3 from 3-1. So the more common form in young people is 3-1, which is a lot of deep sleep and very little full wakefulness, whereas in very old people over 70, you have little deep sleep and a lot more full wakefulness. So I don't know if I answered your question. These are all normal people.
No, I think that's very helpful, just to see that we have quite extensive data, Magdy, from normal populations. I think we're pretty close, Amy. So.
Okay, well, thank you everyone for attending. We will keep you posted on the next sleep rounds and that topic in the upcoming months. And thank you again. Take care.